Yes, good morning everybody, and once again thank you very much for this invitation. Some of the topics, I have to say, have already been covered by Professor Besselink in the first talk, so maybe I can also, maybe not really skip, but go over this pretty fast. And regarding your question, the two-surgeon approach and the one-surgeon approach, I did the first 50 Whipples when we implemented this, always with the same assistant on the table, but then afterwards we opened that up because our system just doesn't allow this for doing this all the time, because then the planning becomes very difficult, and that was the reason why we changed that, and we have quite good experience with that as well. So the talk about history, present and future of minimally invasive pancreas surgery, I want to start very briefly with laparoscopy. Some 25 years ago, maybe you know this paper, probably no benefit seemed to derive from laparoscopic Whipple procedures. So is there any progress that we have made in the last 25 years? I think yes. These are some also already historical data from the US, National Cancer Database, 4,000 open Whipples, or 4,000 compared to 400 laparoscopic Whipples. The outcomes and factors for mortality. When you look at this, you see clearly that there is an east to west problem in the US. The East Coast is probably more developed in this respect than the West Coast as the regional distribution. A lot of centers did laparoscopic Whipples by that time. You see these numbers here. But as you also can see, only 1% of the centers did more than 10 laparoscopic Whipples, and Professor Besselink already addressed this very well, I think. This is not the way to go. This is far too less to have a learning curve and to have good results. And this is also reflected in the results here. You see when you go to a center with less than 10 laparoscopic Whipples, mortality is much higher than in the ones that do more than 10 laparoscopic Whipples, and this is the message that you should take home. So what about the study data? And this I can go very quickly. This is the Hepato trial. You have already heard about this. This was stopped prematurely because of this problem here, this increased mortality in the laparoscopic group. That was a technical problem and a problem of the numbers. Mark already mentioned that. By that time, we did a meta-analysis of the available 3 studies that were also already shown very briefly. And this meta-analysis showed less blood loss to be expected, longer operation time for the laparoscopic procedures, but no difference in the morbidity regarding the pancreas, and no difference in the mortality over all the data. So it was not really dangerous. It was just a problem of the learning curve and probably your expertise. Disappointingly, length of stay in this meta-analysis also no difference, so no advantage for minimally invasive. Then this Chinese study was already mentioned before, so I can also go through that. That came afterwards, and this showed all of these things that you have already seen, but most strikingly, 1 day less in hospital in a 3-week stay in hospital. And I just highlighted this. You can think about yourself, is this important for a pancreatic cancer patient or not? From my perspective, it's a marginal advantage for laparoscopic Whipples. So can we improve this with a robot? Probably we can, and this is also from my experience or from my perspective the future. How can we improve this? For example, we can improve it if we also implement the ERAS programs that probably most of the centers do in the meantime. When you do this for open or robotic Whipples, this is again a study from Pittsburgh, from the Pittsburgh group, you see that the hospital stay with ERAS can be reduced in the robotic group, also in the open pancreatic urodonectomy group. This was not significant here, but significant for the robot. And this is not at the price of higher readmissions or more complications. This is about the same when you use ERAS or you don't use ERAS. This is exactly comparable. And this might cause some cost saving in the end, because already the costs of the robot have been mentioned, and this is a major problem for us, at least in Germany. Now coming to the robotics. A little brief history. When you look at this, this was the development in 1996 when Intuitive got started up. This looks like you repair your washing machine in your garage. This is not the robot we know today, but of course this has changed, and when I see the next slide, you can imagine how this has changed. At the moment, there are 12 million Da Vinci operations worldwide in 22, 70 countries, more than 7,500 systems, and every 16 seconds a Da Vinci procedure is started somewhere around the world, just to have the dimension in this. And the second dimension, of course, is the market. By 2030, the market volume will be about $22 billion, and this, of course, shows you this tremendous increase and this impact of robotic surgery for the future and already for now. The pioneer works were some left resections that were published very classically with the Da Vinci system in 2003. Looks a little old, but more or less the same as the system works today. This was thought to be feasible. And then, of course, Giulianotti was the pioneer in Chicago, and he did all kinds of operations, Whipple, distal, and total pancreatectomies, published this also in 2003. Operation time is okay, I think, for this pioneer works, very good. And morbidity, also very good. Mortality, 12.5. If you do 8 Whipples and 1 patient dies, this is probably bad luck. For the left resections, already very good results by that time, more than 20 years ago now. Today, we have talked about the learning curve already. You don't do any more see one, do one, teach one. This is doesn't make sense, and this is not possible with a robot. So the training, what I personally consider very important, is the biotissue training. I showed you this on Thursday before. These are the models, and you can suture your pancreatic anastomosis with the robot and just practice training. This has been mentioned before as well. And also the learning curves, I can go over this very quickly. Important from my point of view is first do your basic training, phase 1 and phase 2. This is the simulators, this is the biotissues, and then you have these competency, proficiency, and mastery levels that you reach after some kinds of procedures. And this should, of course, be your aim, which means you need a certain caseload, and you need to limit your robotic program to a certain number of surgeons, at least in the beginning. Interestingly, there are no agreements on the numbers of your learning curves, and you see this is not defined for open or for laparoscopic or robotic Whipples very well. The numbers in the literature differ very much between 10 cases and more than 250 cases for phase 3. And this is a little bit of the dilemma, but now more or less in the guidelines this has been defined, and this has also been demonstrated by Professor Besselink before. Another thing is when you do your program, you start your program, how to select the correct patients, and I think this is quite good. Some score to select the right patients for robotic Whipple procedures, and this was developed with 200 versus 600 validation robotic Whipples, and you see these are the critical factors the patient might have. High BMI, ASA score is high, you have an unfortunate location of your tumor, you have an anomaly in the hepatic artery anatomy, a small duct, maybe borderline resectable, and this all can be summed up to a risk score. And when you use this risk score, you see that this is predictive for blood loss, the need for venous resection, and your morbidity. And if you have more than 12.5 points, this doubles your severe morbidity, and probably you should think about doing this Whipple simply open and not with the robot. You can also calculate this score online when you address this internet address. What is very important from my point of view is the standardization. You need a standardized setup in your center. You need a standardized instrumentation. This is just an example how I do this. You don't need to do it the same way, but this is what you have, which means the arm 3 is the dynamic arm where you change your instruments. The other arms are more or less about the same during the operation. And of course, this has also been described in the literature, once again by Giulianotti. He has described 17 steps for the resection phase and for the reconstruction phase to standardize this for your Whipples. This can be seen here, how you should do this. Of course, not every patient can be operated in this standardized way. Sometimes you might have to switch between these steps to make it easier in the end. What about the future? That was the third topic that I would cover in my talk. The extensions. Yes, you can do total pancreatectomies with the robot as well, not only distals and Whipples. What is the literature at the moment? We summarize this in this little overview, 7 studies, 4,000 patients, 600 of them minimally invasive total pancreatectomy. Looking at this, operation time, length of stay, spleen preservation, and delayed gastric emptying is more or less the same, minimally invasive or open. Morbidity seems to be a little more favorable for the minimally invasive approach, as well as mortality. Blood loss and transfusion is clearly superior for the minimally invasive approach, so this might be the advantages we have to show, but this is not randomized data, this is just a literature overview. What about more advanced procedures with vascular resections? These are what the guidelines say, the Miami guidelines, as well as the guidelines by Liu Rong from China that have been adopted in the world as well. This should only be done in very experienced centers. You should not try to do a venous resection in your first 50 cases, probably. You need much more experience to do this safely, otherwise you will just end up with some bleeding and conversion, and this is not good for the patient. However, if you can do this, you can also extend it to vascular resections. There are studies on this, how you do this with a robot, several studies in the meantime from these experienced centers. And I just want to show you the beginnings. This is a study from Pisa, Ugo Boggi again, 116 robotic Whipples, 14 portal vein or superior mesenteric vein resections. This can nicely be done. You see these intraoperative pictures. Looks very nice, very clean, very well done. But you need a longer operation time, more blood loss, transfusion, and in this series mortality was 22%. This is certainly too high. I think this is also only reflecting some kind of learning curve for this team, and maybe the mortality nowadays is much lesser in Pisa as well. Again, what to extend more? This is the modified Appleby procedure. Maybe Melissa Hock will comment on this also later. This is again from the Pittsburgh group, 30 modified Applebys, 11 of them robotically, all of them nearly for pancreatic cancer after neoadjuvant therapy. Again, very nice pictures. You can do this. You can staple the celiac axis with your vascular stapler and the arteries are safely closed. The outcomes shown here and the baselines, you see there was not a big selection bias in this study, more or less all of the same. Patients were not very selectively associated to one or the other group. In the end, what you see is in the very experienced centers, robotic procedures are quicker than the open procedures. That's also true in the Netherlands, as I just learned from Mark Besselink. You have much less blood loss, of course, and you need zero transfusion in these patients with this huge experience for this very extended procedure of a modified Appleby with a robot. Outcomes regarding the tumors are about the same. Again, not really hardly selected these patients, and the survival, open or robotically, is exactly the same. It doesn't matter what you choose for your approach, it only matters how radical you operate. If you have R0, this is significantly better than R1. If you have R0 with a robot or open, doesn't matter at all. What else is coming up or might be coming up in the future? Chronic pancreatitis has been described with drainage procedures. We heard about this in the last session, endoscopic or surgically. Of course, I'm a friend of surgical therapy for chronic pancreatitis. You can do this, the lateral pancreatic duodenostomies. You can also do the duodenum preserving procedures. We have started doing these in Hamburg now. We have done 5 robotic duodenum preserving head resections with good results at the moment, and we will continue doing this. But I think it's not so many centers in the world at the moment approaching this with a robot. Then, of course, you can expand this even further. You can do pancreas transplantations with the robot. This is, again, the Boggi group from Pisa, and also Oberholzer from Chicago and now from Zurich. These are maybe the people who have done this. Boggi has stopped it as far as I know. Oberholzer tries to continue with robotic pancreas transplantations. However, if you have in all of Switzerland 11 pancreas transplantations over the year, how should you learn this with a robot? How should you ever teach any surgeon to master this in the end when the whole country has 11 pancreas transplantations and you try to approach with the robot 1 or 2 of them? From my point of view, this doesn't make sense. We should probably not do this. However, the results, if you do it, the 3 cases from Pisa, one of them with simultaneous kidney transplantation, 5 hours, 8 hours are the operation times. Not bad. Some people need that for open simultaneous pancreas kidney transplantation as well. You have, again, additional costs, which may be not covered, of at least 4,000 euros. Benefits you need to, yes, consider, probably not really important in this group of patients. If you have diabetes, you get a pancreas. Does it matter if you have an incision like this or an incision like that? Because you have to get the pancreas in the body anyway. So, from my point of view, not a big difference. Regarding evidence, Mark Besselink talked a lot about the randomized studies for laparoscopic. For robotic, at the moment, this is what is published every year, and this is what is published in a randomized controlled trial fashion. You see 2 RCTs on some technical aspects are published. 3 study protocols were published, and 2 studies are finished now. This is the Europa trial, and this is, of course, the Dutch trial that Mark already mentioned. They will both be soon online, I think, latest beginning or mid of next year, and then we will have better evidence regarding this. Just for the last 2 slides, one little word of caution. I told you the market, the industry, the money in this system. This is some little study I like from 2019. How are studies influenced by the industry sponsoring? 9 RCTs, 24 observational studies that used robotic approaches and were sponsored to some extent by the most prominent company that sponsors these things. And you can see very nicely that there is a kind of a cutoff. If you have a sponsoring of less than $10,000, the results tend to favor the non-robotic support approach, and the robotic approach doesn't seem that good. If you have a sponsoring of more than $10,000, suddenly the robot becomes much better and the open approach becomes less good. Of course, this is very polarizing, I know, and this is certainly not high-level evidence, but just to keep that in mind, we need independent evidence to talk about this and not any studies that are sponsored by 1, 2, 3, 4, 5 companies, and maybe the outcomes are sponsored as well. Thank you very much. I think this was a little overview, past, present, and future, and happy to discuss.